Welcome Dr. Stephen Black as our special guest. Dr. Black is a consultant vascular surgeon at the Guy's and St. Thomas's Hospital in London. He's also the professor of venous surgery in King's College and a pioneer in new cutting technologies and published extensively and given talks worldwide. So Dr. Black, welcome.
Thank you, Neil. Delighted to be here.
So we all know that with DVT, the principal effort is to unblock the vessel and restore normal venous flow. But now this new field of research that you're involved with this new technology, looks at the role of inflammation in the thrombus and how it can lead to chronic syndromes if left unaddressed. Can you tell me more about this?
Yeah, thanks, Neil. So, we all know that clot forms in response to vein wall injury, which is causing local inflammation. And that static or sluggish flow in the vein and systemic activation of anticoagulation, in other words, Virchow's triad, causes thrombus to propagate as a consequence. And so the body tries to remove that by organizing it into thrombus and then activating the inflammatory cascade, which leads to lysis and cleaning up of the blood vessel. And this is precipitated by influx of monocytes and macrophages, which do the work. Amongst other things. But this inflammation can often be excessive, and we've all seen those patients who have, I've had patients where we thought they've got sepsis as a consequence of the massive inflammatory response they've mounted to extensive thrombosis. And so when this happens, the process of resolution of that clot can lead to collagen formation, and that obviously causes scarring, as it does everywhere else in the body. And that means that the vein, which is supposed to be a capacitance vessel and needs to be compliant, loses that ability. And it can do that by either making the vein stiff, or it can do it by destroying the valves, which lead to problems with reflux and obviously outflow obstruction. So the problem when we do interventions on patients, and especially now as we're moving into this area of mechanical thrombectomy, where we are treating patients perhaps further down that pathway with some of the newer devices, that inflammatory reaction has already started. And sometimes the act of intervention makes it even more pronounced. And so what the concept is that if we can deal with that inflammatory response and shut it down, we give the body a better chance to heal. And steroids, which are already commonly used for that exact purpose, seem to be a very good place to start.
From a clinical standpoint, from the patient's perspective, what happens if you don't treat the inflammation?
Well, as we alluded to, it leads to the higher potential for scarring. And I think that's why we see such high rates of PTS in patients that we don't treat. And if you think of the femoral vein population that we routinely don't treat, and most of people advise against, the PTS rate is still 40-45% in that group, which is quite alarmingly high. And a lot of those patients become moderate and severe. So we know from preclinical studies that inflammation leads to larger thrombus formation. It leads to thicker vein walls and greater collagen content in the vein afterwards. And when we've delivered dexamethasone in animal studies and compared it to saline, we see a big reduction of thrombus size and a thinner vein wall near to normal at the end of that thrombus resolution phase, and a clear reduction in collagen levels, which are close to back to normal levels. So in humans, the inflammation that remains after thrombus removal is hypothesized to be a key driver for that long-term chronic problem, which we call post-thrombotic syndrome, and that leads to pain, swelling, discoloration, etc. So if we get onto treating inflammation early, and there's some data from multiple trials in the anticoagulation world that show that managing the inflammatory response of DVT is quite crucial to good long-term outcomes. So that's the driver for the inflammatory modulation.
And of course, in the worst case scenario, they end up with ulcers, which can be quite morbid and quite expensive and quite demand a lot of care. But so can you tell us about this new device that you're using in this study, the Bullfrog microinfusion device? How is it being used in this patient?
Yeah, absolutely. So I'll share some pictures of it because it's helpful to see those in action to understand what's going on. So basically, what you get with the Bullfrog device is you get a specially designed balloon that when you inflate the balloon, it's a bit like a taco shell opening up or the Bullfrog opening up. The tip of a needle protrudes from within the balloon, as you see in the picture now. And that is about 1.8 millimeters, the needle length, and it allows you to penetrate into the adventitia of the vein and then inject steroid directly into that part of the vein wall. And you can see that here. So it actually doesn't go through the vessel. It puts the drug right where you want it, which is in the vessel wall itself. And you can see this patient here, which is a patient of David Dexter's actually, who is in the trial that we're doing, where you can see that in action. The balloon inflates, you inject the drug, we lace it with some contrast so you can see it, and as you see it infusing around the vessel wall, you move down over treatment sections. So to treat the whole femoral vein takes about 5 minutes, and it's about 20 seconds per every couple of centimeters that you do with the balloon.
This new technology seems like a very efficient and direct way to put medications directly into the vessel wall, into the vein wall. What are some of the potential upsides of this? And of course, what are some of the risks?
Yeah, so I think we've always seen that systemic drug delivery is not as good as others, and we'll probably get onto that in a few minutes. But this process works quite simply. It works quite elegantly. You're not limited to volume of drug you can deliver through the device because it's a handheld syringe at the user end, so you can do as much or as little as you need to treat a whole section. It's already been FDA cleared and CE marked for use with dexamethasone. So hopefully, if we see the trials that we're currently running play out in the way we hope, that we'll see some compelling evidence for a DVT mechanism of action. And of course, dexamethasone is the obvious choice for an anti-inflammatory reduction. It's cheap, it's readily available, there's good data to support it. So that makes sense, but it's not limited to one drug because you're injecting whatever you need to through it. So future therapies could develop to be targeting specific aspects of the clot biology as we start to understand that in more detail and work out what the mechanisms are to reverse that. Downsides, it adds a little bit of time to the procedure, but nothing substantial. As I said, a couple of minutes for treating the whole femoral vein segment. You have a single needle, so you have control over that injection. If you try and put multiple needles on it, you don't know which one the drug's going to go out because it always goes through the path of least resistance. And the balloon can go from 6 to 16 millimeters, so we can kind of cover the whole width of the iliac down to popliteal vein, which is really what we want to treat. So, and dexamethasone is well tolerated in these doses. So, it's if it works, it's great. If it doesn't, we'll see from the studies, but it makes sense at the moment.
I want to pick up a little bit on that theme that you were talking about. Are there alternative ways of delivering these steroids, such as a simple oral dose of steroids to have the anti-inflammatory effects on the DVT? Could you get the right levels of the drug to build up in the vein wall just with oral steroids?
Yeah, I mean, that's a great question and a common one, isn't it? And I think when I've presented this, I've been asked that probably every time. I think mainly Alan Davies is the culprit on each occasion. But, you're delivering locally around 100 milligrams of drug into the vein wall. And that is what you need to build up the right levels in tissue. So, and you want it working where you want it working. Systemic steroids have a lot of downsides, and patients tolerate those poorly, but you want it in the vein where the inflammation is. So if you wanted to get that level with a 100-kilo patient, you'd need to deliver 100 grams of drug systemically to reach that level. So if you're looking at dexamethasone, which is typically 2 milligrams of drug in a typical tablet, you're talking about 50,000 tablets, which is just not feasible. So and I think in all other spheres where we've looked at systemic delivery versus localized or delivery of drug, the localized delivery has always played out to be the better strategy. So I think it's more than about steroids. It's about that ability to drive a drug to where you want it. So the stem cells and the future that we look at deliver it where you want them rather than anywhere.
So in this study, what type of outcomes are you looking to achieve? And what outcome would warrant this treatment becoming part of the algorithm to treat deep venous thrombosis?
Um, so I'd say that right now, upwards of 40% of the patients that I see who present with DVT are either femoral vein DVT, or they're beyond the window of treatment, or they're out with of what we can do anything for them. And so those patients still end up with quite severe post-thrombotic syndrome. We've all got those patients coming to our clinic who had a FemPop DVT, which is left alone, and now they got PTS. So the question for me is, we've had multiple negative studies. If these studies show benefits, and even if we're reducing the risk of PTS from 45% to 20%, I think that's a big win. So it's not necessarily about eliminate it completely. And again, as we saw with ATRAC, the argument is taking patients from moderate to severe to mild or nothing. So the absence of PTS may not be achievable, but we can certainly downscale the severity. And it's, as you mentioned earlier, the severe end where we get leg ulcer and significant venous claudication, which really destroys people's lives. And we've all got those patients who are in their early 40s who are going, really, is this the best my leg's going to be? And I think, again, treating this early when we can get the vessel back to normal, rather than trying to deal with that as a chronic problem, will be a good thing.
I want to pick up a little bit more on that idea about femoral popliteal vein DVTs. Do you think that this could be used as an adjunct to standard therapy for femoral popliteal vein DVTs if you, let's say, remove their clot and then add an anti-inflammatory?
Totally, and I think we've again all got those patients, and we've seen several presentations now from Huma July, who's come up with this classification for post-thrombotic syndrome, and we all recognise in all the ID studies of stenting that in the chronic group and even in the acute group, patients with poor inflow and already damaged FemPop segments, and often those are the ascending DVTs that have started with popliteal vein disease and then block the iliacs. If you try and open that up and you've got poor inflow, you get poor results. And we got some promise out of Mark Garcia's work with the Access PTS study, but that still hasn't seemed to really shift enough of those difficult inflow patients. So we clearly need to do something more to that group. So I think that difficult, complicated inflow disease in the FemPop segment, which is a large group of patients, if there are adjunctive therapies to just a balloon and stent that help to improve the patency in those patients, and we start with dexamethasone, and obviously the future is open to what other drugs might be amenable, but they can be delivered through the same system. I think that's an exciting possibility.
You started the Dexterity study looking at this device, and you're one of the principal global investigators. Who's being studied in these trials?
So we're currently running two studies. There's one study focused on acute DVT in the early presentations, and that study is being led by David Dexter and Mahmoud Razavi. And then there is the subacute to chronic group, which is being led by Jerry O'Sullivan and myself. And so we try to split the studies to look at those different phases of disease. So really early with fresh clot, where your chances of getting it out are pretty high and you're going to be successful. And then that group that currently a lot of people would leave alone. So, we've all debated, when you get somebody who's 5-6 weeks into the disease state, are you going to wait for them to get to PTS at 6 months or 1 year even? And that group are all going into thrombectomy, and it's been aided a bit by the availability of devices like Inari's ClotTriever, which are showing benefit on, or the potential to remove the older, more chronic material. So the combination seems to be potentially very effective. And so what we've got at the moment is we started with the studies recruiting a 20-patient pilot phase, and then you go into a randomized phase where patients be randomized in a blinded fashion to dexamethasone or saline placebo. And so the acute study has completed the 20-patient enrollment phase and is moving into the randomized phase. and the chronic study is just a little bit behind, but close to completing that early phase. And that's allowing us to benchmark the blood test work and all the other measures that we're doing of inflammation to make sure that we're on the right track.
So with this technology, the Bullfrog microinfusion device, is it a standalone therapy for DVT, or do you combine it with other therapies with opening the vein?
Yeah, so I guess conceptually, the way that an open vein hypothesis works is you have to open the vein first, and then you have to keep it open. And we've seen from ATRACT and CAVA that a high percentage of patients in CAVA, it was 50, and in ATRACT, 40 to 50%. In the follow-up data, thrombosed their vein again. So the first part is getting it out, which we've got lots of technology for. And the second part of keeping it open and giving it the best chance to stay open is where I think the Bullfrog comes in. So I think these technologies are synergistic, and it is agnostic to the method you have of removing clot. You want to get it out, put the drug in, and then allow the vein to restore itself back to normal with the best chance of that collagen inflammatory phase being modulated.
So looking forward, this sounds like this device could be used, as you mentioned, to deliver all types of drugs, not only into veins, but into arteries, and not only in the lower extremities, but almost any place.
Yeah.
Are there some other applications that we're looking at?
Well, I think Bullfrog obviously didn't start in veins, and they've done some work before in PAD in the coronary space, and including in things like renal denervation, where the device can deliver ethanol directly to the renal artery perivascular tissue, for example. So it's a cross-platform drug delivery system in many respects. And so we know that in peripheral artery disease, for example, the results of DCBs in the BTK population have been disappointing. And that might be because of where the drug is being delivered. And so potentially adventitial delivery might be advantageous. And Dexterity, before Dexterity, Bullfrog had some really fairly reasonable results with Limus in the BTK segment in PAD. So I think that's encouraging. And then obviously looking forward into the future, I think the development of novel stem cell technologies that can be delivered directly to where you want them, as opposed to systemically or randomly, may be helpful. So you think of the claudican population, for example, where stem cells may not treat the disease, but may encourage peristenotic collateral formation, or help those patients where at the moment the results of treating claudicants again are not as good as we'd like. I think those are potential things.
Sounds like a really great opportunity. It's a really unique delivery device, and it can be used possibly in multiple settings. So we're really looking forward to the results of these studies.
Yeah.
And thank you very much for educating us and giving us a little insight into this new exciting technology.
My pleasure. My pleasure. It's always great to talk to you, and I hope we see some encouraging results in the future.
Thank you. Thank you very much.
My pleasure.